Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a hard cataract with mid-dilated pupil. At this moment, I don't know whether pupil will constrict during emulsification of the nucleus or not. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome at mid-limbus. This is a side port on the left side of the main incision about 3 clock hours away. And now an air bubble is injected into the anterior chamber. Underneath this air bubble, trypan blue 0.06% dye is applied over the anterior capsule. I am taking care not to touch the iris so that the pupil size is maintained. I have injected a bit of adrenaline and now the dye is washed out. I am always beyond the iris so that size of the pupil is maintained. And now the anterior chamber is filled up with OBD. This is 2% hydroxypropyl methyl cellulose. It is applied over the corneal epithelium for better visibility. We can see that the pupil has dilated little more by adrenaline. We can see the white margin around the stained area. And now this is rhexis. I am doing as large rhexis as possible in this case. So I am going along the margin of the dilated pupil, along the border of the dilated pupil, and I have got an adequate sized rhexis. And now hydrodissection is done very gently. Again, I am in the capsular bag, beyond just underneath the anterior capsular rim, and I am not stroking onto the iris. Visco is again injected, and now is the time to introduce the phaco needle. Here it goes. The exposed part of the phaco needle is okay for this case. Aspirated some superficial lens matter. This is cortex as well as epinucleus. Now the nucleus is exposed. And now my plan is to do submarine chop to divide this nucleus. The tip is buried into the substance of the nucleus. It goes through the substance towards the opposite equator. And now the chopper is used to get a crack, and I have got a very nice crack. And now I rotate the nucleus 180 degree and divide the nucleus completely into two heminuclei. Now each heminucleus is subdivided into two pieces, and this piece is being emulsified. The piece on the left side is being emulsified. And now I get onto the other piece. It is divided into smaller pieces and they are emulsified. So one heminucleus has been managed. Now I come to the other heminucleus, go through the substance of the heminucleus so that the purchase is very firm, and it is divided into two large pieces. The lens is tilted and the fragment on the left side is emulsified. Emulsification is started from the apex. And now the last nuclear piece. Let me tell you the setting. Ultrasonic energy is 75% from the very beginning. flow rate is 40 ml per minute, and a vacuum is 400 millimeter of mercury. The machine being used is Faros from Otley, Switzerland. And this is a bit of cortex, it is removed. And now there's a piece of epinucleus which is under the iris at around 8:45 o'clock. I want to remove that by the phaco needle itself because it may be difficult to remove it by bimanual irrigation aspiration or a Simcoe cannula. So I inject visco, go again, and just use vacuum to pull it at the center and emulsify it with a little bit of ultrasonic energy. And now cortical cleanup is being done. In this case I have used this 23 gauge Simcoe cannula for removal of the cortical matter. Simcoe is very gentle and one can get more control, particularly when you are working under the iris, when you cannot see the cortical matter. This instrument works very well. So cortical cleanup has been done very satisfactorily by this instrument, and now is the time to implant an intraocular lens. The antechamber as well as the capsular bag is filled up with 2% SPMC. And now an intraocular lens. This is a hydrophobic acrylic single piece monofocal intraocular lens from Hoya, Japan. The lens comes in a beautiful preloaded system. The tip of the cartridge goes into the anterior chamber through 2.8 mm wound, and you can deliver the lens very nicely in the capsular bag. Yes, the lens is nicely in the capsular bag, and now I want to check whether any cortex or any nuclear piece is hidden under the iris or not before I start removing the visco. So this is an instrument which is shaped like the letter Y, and we can retract the iris very nicely, and we can check all around to see if any nuclear fragment or any cortex is there or not, and we can check whether the IOL is in the capsular bag or not. Yes, it is in the capsular bag. And now visco is removed both from the capsular bag, going behind the intraocular lens, as well as from the anterior chamber. Irrigation and aspiration is used for adequate time. This is only irrigation, and now I use irrigation plus aspiration to remove all the visco molecules. So visco is nicely removed, and now is the time to conclude the case. This is a bit of moxifloxacin. The side port, the only one side port has been made in this case. The side port is closed by hydrating corneal stroma on either side of this wound. And finally final lavage, concluding lavage of the anterior chamber with the Simcoe. At this time, a gentle stream of BSS is directed towards the corneal endothelium to remove any visco sticking to the corneal endothelium. The antechamber is nicely formed, and then integrity of all the wounds are checked by a cotton-tipped Johnson bar. Few drops of moxie is applied over the cornea and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion and great surgical competence.